Okay, let's settle in. Today we're really diving deep. We're tackling the world of skin cancers, and our guide is this incredibly detailed source, Chapter 76, Cancer of the Skin.
Yeah.
It's a key text for, professionals in the field.
Oh, absolutely. This chapter is just packed. It takes you from the very basics, what these cancers are, who tends to get them, what causes them, all the way through the really fine details of their genetics, how we actually diagnose and stage them, and crucially, the treatments. And how those treatments are changing. We're covering melanoma, which people often think of as the most serious.
Right.
And also the non-melanoma skin cancers, which are actually much more common.
And our mission here, for you listening, is to pull out the most vital stuff from all this information. We want to connect the dots, link the genetics to the risk, the staging to the treatment options. So you can build a really solid understanding, like getting the expert view, really mastering the core ideas of this chapter without having to wade through the whole text yourself.
Exactly that. It's about getting beneath the surface, understanding the why behind what doctors do, the basic biology that shapes how we diagnose and treat these things.
Great. So let's jump straight into melanoma. It's the one people often worry about mostly because it can, spread fast if not caught early. What exactly is melanoma?
Fundamentally, melanoma is a type of cancer, an aggressive one, that starts in cells called melanocytes. These are the cells that make pigment in our bodies. And what's really interesting, kind of unexpected, is where they come from during development. They actually originate from the neural crest.
The neural crest, that seems, an odd link. Skin cells starting out near nerve development.
It is a bit surprising, isn't it? So from this neural crest, the melanocytes migrate, they spread out. Most end up in the skin, obviously, but they also go to other places, like the layers covering the brain and spinal cord, also mucous membranes, part of the upper esophagus, and the eyes, too.
Wow. So does that mean melanoma could technically start in any of those spots?
That's exactly right. You can get melanoma in the mucosa, in the eye, even in the meninges. But, and this is really key for finding it and for the outlook, the vast, vast majority arise in the skin. That visibility is crucial. It means we can often spot them just by looking. And if you catch melanoma early, before it goes deep or spreads, just cutting it out surgically gives a really high chance of cure.
That visibility is a huge advantage then. Does it hit everyone the same, or are some people more likely to get it?
Cutaneous melanoma, the skin kind, can affect anyone, really. All ages, all skin colors. But the risk factors and how common it is, that's heavily shaped by a person's genes, the specific biology of their melanocytes, and of course their lifetime exposure to UV radiation from the sun, UVR.
And the source material mentions that both melanoma and the other skin cancers, the non-melanomas, are actually getting more common.
Yeah, that's a definite trend we're seeing worldwide. And while the non-melanoma types are way more numerous, melanoma causes more than half of all skin cancer deaths. That just underlines how aggressive it can be if it gets advanced. The rates vary hugely, though. Depending on ethnicity where you live, it all comes back to that mix of genes and environment. For instance, populations with lots of that protective brown or black pigment, eumelanin, might have rates as low as, say, 1 case per 100,000 people a year. But in populations with less melanin, later skin, it can jump way up, maybe 27 cases per 100,000. That difference really shows how protective melanin is.
Really puts skin type into sharp focus, doesn't it?
It does. We also see a slight difference by sex, a bit more common in men, maybe a 1.3 to 1 ratio. Yeah. And the average age when it's diagnosed is usually in the late 50s. If you look at specific numbers, like the U.S. estimates for 2020, melanoma was the 5th most common cancer in men, 6th in women.
And those are the invasive ones, the ones that have started to spread deeper.
That's right. Those 2020 U.S. numbers predicted about 100,000 new invasive melanomas. But interestingly, the source also points out there were almost as many, again, about 95,000 cases of melanoma in situ.
In situ. What does that mean here?
In situ basically means the cancer cells are still stuck in the very top layer of skin, the epidermis. They haven't broken through to the deeper layers yet. It's like stage 0 melanoma, the earliest possible point. And the source raises an interesting possibility. Given that overall death rates for melanoma have been pretty stable or even going down slightly, especially in the U.S., it suggests some of these new diagnoses, particularly the in situ ones, might be, overdiagnosis.
Meaning we're finding some that might never have caused a serious problem anyway.
Potentially. Lesions that maybe, even if left alone, wouldn't have progressed to become life-threatening. It's a complex issue in cancer screening generally.
That's a really important point. How have the actual death rates been trending?
Mortality, it starts to climb around age 55, peaking in men over 65. But the good news, especially in the U.S., is that unlike the rising incidence, the death rates have been decreasing. It's not quite as dramatic outside the U.S., but here it's partly thanks to the big breakthroughs we've seen in melanoma treatments recently.
So new therapies are actually saving lives from this thing.
Absolutely. There's a striking statistic in the source. After drugs like ipilimumab and vemurafenib got FDA approval back in 2011, the one-year relative survival for metastatic melanoma shot up. It went from 42% between 2008 and 2010 up to 55% just a few years later, 2013 and 2015. And between 2013 and 2017, death rates were dropping annually by about 7% for people aged 20 to 64 and 5-6% for those 65 plus. That's real progress.
That's huge. What about the global picture? Still increasing there?
Yeah, globally, incidence is still rising. Back in 2018, the estimate was around 300,000 cases worldwide. And interestingly, a disproportionate share of cases and deaths happen in North America, Europe, Australia, and New Zealand, which loops back again to that core idea. The interplay between a population's genetic skin type, pigment, and environmental factors like UV levels, distributing the risk unevenly.
You touched on melanoma in people with darker skin being different. Can you expand on that?
Right. The incidence rates are way lower, like 10 to 20 times lower in populations with more natural eumelanin. Think people from India, Puerto Rico, black populations, East Asians compared to white populations. SEER data from the early 2000s showed rates around 27 per 100,000 for whites versus maybe 1 per 100,000 for black individuals. But the challenge is when melanoma does occur in people with darker skin, it often gets diagnosed later at a higher stage, and the outcomes tend to be worse.
And the location is different too, you said.
That's a key point. In non-white populations, you see melanomas much more often in what we call acral sites. That's palms of the hands, soles of the feet, under the fingernails or toenails, and also on mucosal surfaces like inside the mouth or nose. This is different from white populations where it's more commonly linked to sun-exposed skin. And crucially, the incidence in black and Hispanic populations doesn't seem to be linked to UV exposure in the same way.
So different drivers might be involved.
It strongly suggests that, yes. Different primary causes or mechanisms might be more important in those populations and locations. The situation in China, for instance, with rising cases and deaths, might be tied to more melanomas starting in acral sites and just being found later. And generally, regardless of ethnicity, melanomas on mucosal or acral sites tend to have a poorer prognosis than those starting on typical skin surfaces.
So it's definitely not a one-size-fits-all UV story, which brings us neatly to risk factors. What makes someone more likely to develop melanoma?
The source material breaks down the clinical risk factors into roughly 3 buckets. First is anything that makes your skin susceptible to sun damage. So having light or red skin, light hair or eyes, skin that already looks sun damage, a history of a lot of UV exposure, whether natural sun, or, importantly, tanning beds, and also having had any previous skin cancer.
Wait, so having had a basal cell or squamous cell cancer increases your risk for melanoma specifically?
Yes, that's considered a known risk factor. The second main category relates to abnormal melanocyte growth patterns. This means having a lot of moles, having unusually large moles, or moles that look atypical, weird shapes, multiple colors, speckled patterns.
The ugly duckling sign, the one that just looks different from the others.
Exactly. That's the clinical observation tied to this risk. And the third big category is immunosuppression. Whether it's an innate immune issue, a functional problem, or drug-induced suppression, like for organ transplant patients, it increases the risk.
Can we look at how much these factors increase risk? The relative risk numbers from Table 76.1.
Yeah, understanding relative risk is useful. It tells you how much more likely you are compared to someone without that factor. So, for example, having just one atypical mole, or nevus, increases your relative risk about 1.5 times compared to someone with none. But if you have 5 or more atypical nevi, that risk jumps way up to about 6.4 times higher.
Wow.
And the total number of just plain common moles matters too. Having, say, 16 or more compared to fewer than 15 gives a relative risk of maybe 1.5, but having a really high number, like 81 to 120, puts you in a high-risk group with a relative risk close to 7.
So it's not just the odd-looking ones, but the sheer quantity, too.
Correct. Past sun exposure is huge. A history of sunburns compared to never having had one roughly doubles your risk. Relative risk 2.0. Indoor tanning is highlighted as particularly risky, especially for younger women. Under age 30, indoor tanning carries a relative risk of about 6 compared to never doing it. Skin type 2. Fitzpatrick type I, very fair. Always burns, never tans, has about double the risk, 2.1 compared to type IV, which tans easily.
And the family history and genetics we mentioned.
Right. Having a first-degree relative, parent, sibling, child with melanoma puts you at moderate to high risk, maybe 1.7 to 3 times the baseline risk. Having had melanoma yourself is one of the biggest risk factors for getting another one relative risk somewhere between 8 and 13 times higher. And carrying one of those inherited gene mutations, specifically in CDKN2A, puts you at very high risk, maybe 14 to 28 times the risk of the general population.
That 14 to 28 figure for CDKN2A carriers is really striking. It shows just how powerful those genetic links can be. Let's unpack that inherited risk a bit more.
Definitely. Genetics is a big piece, though it's complicated. Maybe 20 to 40% of hereditary melanomas, which themselves are only a small fraction, maybe 0.2 to 2% of all melanomas are linked to these inherited germline mutations. But understanding them is key for high-risk families.
And CDKN2A is the main player here.
It really is. It sits on chromosome 9p21. And what's pretty remarkable is that changes, mutations, or deletions in this gene are found in something like 70% of all cutaneous melanomas, not just the strongly familial ones. It's a clever gene, too. It uses what's called alternative reading frames to make 2 totally different tumor suppressor proteins, P16 and ARF, which is also called P14 ARF.
So like one blueprint can build 2 different safety systems.
That's a great analogy. And both are critical brakes on cell growth, targeting key pathways. P16 inhibits enzymes called CDK4 and CDK6. These enzymes normally switch off the retinoblastoma protein, RB. RB is a major gatekeeper for cell division. When it's active, cells don't divide. The other protein, ARF, stops a protein called MDM2 from degrading P53. And P53 is another crucial guardian involved in stopping the cell cycle or triggering cell death if there's DNA damage.
So if you lose CDKN2A function, you essentially lose both P16 and ARF. You're disabling 2 major safety pathways at once.
Exactly. The consequence is knocking out both the RB pathway and the P53 pathway, 2 fundamental controls over whether a cell divides or not, like taking out 2 critical fuses. And there's another link. Families with these germline CDKN2A mutations also have a higher risk of pancreatic cancer. It's not just about the skin.
Are there other genes that confer such a high risk?
There's a second high-risk gene, CDK4, on chromosome 12q13. This gene makes the actual enzyme that P16 inhibits. So mutations here also mess up the RB pathway. But CDK4 mutations are much, much rarer as a cause of inherited melanoma risk compared to CDKN2A.
What about genes that increase risk but maybe not quite as dramatically, moderate risk factors?
Yeah, that brings us to things like the melanocortin-1 receptor gene, MC1R. This gene is really important for how melanocytes work. UV exposure triggers a hormone, AMSH, which binds to the MC1R receptor. Normally, this signaling tells the cell to make the protective brown-black pigment, eumelanin.
And variants in this gene are pretty common, I understand.
Yeah, very common. MC1R is super variable. There's something like 80 known variants. Many of these variants cause the receptor to not signal properly, either partially or completely. When that happens, the melanocytes make less eumelanin and instead make more of the red-yellow pigment, pheomelanin, which isn't very protective against UV. This is the genetic basis for the classic red hair phenotype, fair skin, red hair, freckles, burns easily, and a known higher risk of melanoma.
So the higher risk isn't only because that red-yellow pigment is bad sunscreen.
This is where it gets really fascinating, and it's more than just poor UV shielding. Besides pheomelanin being a weak UV blocker, research now shows that having more pheomelanin because of these MC1R variants actually contributes to cancer development in a way that's independent of UV exposure. It seems to promote oxidative damage inside the melanocyte itself. So it's adding another layer of risk beyond just failing to block the sun. That's a really key insight.
Wow, that's quite something, the pigment itself potentially causing damage and not just failing to protect.
It is. So beyond those major players, there are other genes like MITF, BAP1, POT1, TERTs linked to melanoma families, but we're still figuring exactly how much risk they carry. And then there are loads of common genetic variations, polymorphisms, in genes related to pigmentation, mole count, immune function, DNA repair, metabolism, even the vitamin D receptor. Each one might only have a tiny effect on its own, but added together they contribute to someone's overall genetic tendency.
So pulling it all together, the genetics picture is complex. A few big hitters, a common moderate factor like MC1R, and lots of small contributors. How much of the inherited risk can we actually explain now?
Right now, we think about 50 to 60% of the genetic risk for hereditary melanoma can be linked to these known genes. And of that known risk, CDKN2A accounts for maybe 40% of it, the rest. It's likely a mix of other genes we haven't fully pinned down yet, or maybe shared environmental factors within families that we haven't teased apart from the genetics.
Okay, understanding all these risks naturally leads to thinking about prevention and catching things early.
Yeah.
What can people in the healthcare system actually do?
Right, so primary prevention, stopping the damage before it starts, is really all about sun protection. And we know it works. Public health campaigns, like the SunSmart program that started in Australia and is now used elsewhere, have clearly shown that changing people's behavior around sun exposure can actually lower the rates of both melanoma and non-melanoma skin cancers.
And when's the crucial time to start being careful?
Ideally, right from childhood. The UV damage starts building up really early, even though the cancers might not show up for decades. Some studies even suggest that getting badly sunburned as a kid might be a bigger risk factor than just chronic tanning later on.
That's a powerful message for parents.
It really is. And the source mentions something interesting that can make prevention tricky for some people. Tanning addiction. It seems to be a real thing, linked to compulsive tanning behavior. There might be differences in dopamine pathways in the brain's reward centers. There's even evidence UV exposure can trigger endorphin release in the skin, contributing to that drive. So identifying people with this pattern could be a specific prevention target.
Fascinating link between addiction, brain chemistry, and skin cancer risk. So what are the specific recommendations for sun protection?
The basics are wear protective clothing, wide-brimmed hats, sunglasses, use sunscreen importantly, broad spectrum, meaning it covers UVA and UVB, with an SPF of 30 or higher. Apply it generously and reapply often, especially if you're swimming or sweating. The source mentions physical blockers, like zinc oxide and titanium dioxide, might be less likely to cause allergies or get absorbed than chemical sunscreens. And the absolute key advice: avoid sunburns like the plague. Stay away from tanning beds completely. The link there is undeniable, and try to limit time in the strong midday sun.
Okay, so that's primary prevention, avoiding the initial damage. What about secondary prevention? Finding it early if it does develop.
Secondary prevention is all about early detection through education and screening. And screening should really be tailored based on someone's individual risk. For people we know are at higher risk, say someone with those clinically atypical moles, dysplastic nevage, or anyone who's already had a melanoma, a full-body skin exam by a doctor or trained professional is definitely a good idea.
And for the very highest risk folks,
dermatologist surveillance is recommended. That might involve things like total body photography to keep track of moles over time, and using dermoscopy for a closer look at any suspicious spots. Genetic testing might also come into play in specific situations, like if someone's had 3 or more primary melanomas, or there's a strong family history, say, 1 invasive melanoma plus 2 other cases of melanoma or pancreatic cancer in close relatives on the same side. That CDKN2A link again.
And if suspicious things are found during these checks.
Well, atypical moles that look really concerning, and melanoma in situ, those very early forms, should definitely be removed. The huge benefit of catching things early, whether it's these precursors or early invasive melanomas, is that the treatment is usually much simpler, often just cutting it out. That leads to much higher cure rates and less complicated recovery compared to treating advanced disease.
Can people play a role in their own detection? Self-checks.
Absolutely, and it's vital. Monthly self-skin exams really complement professional checks. Patients need to be taught what to look for. The standard reminder is the ABCDEs of melanoma: asymmetry, border irregularity, color variation within the mole, diameter usually bigger than a pencil eraser, about 6 millimeters, though they can be smaller, and importantly, evolving any changes in size, shape, color, or symptoms like itching or bleeding. And also that ugly duckling sign: if one mole just looks different from all the others on your body, that's a flag. Get it checked.
Is there solid proof that these kinds of screening efforts work on a population level?
Well, public health campaigns, particularly in Australia, combining media messages about sun safety and screening, have shown positive results. They've changed attitudes and behaviors and seem to have helped reduce melanoma rates. One analysis even showed a good return on investment. However, it's important to mention the U.S. Preventive Services Task Force. They currently say there isn't enough strong evidence to recommend routine, full-body skin screening for everyone in the general population who doesn't have symptoms. They acknowledge research is ongoing to figure out the best way to do screening effectively for the broader population.
Okay, so targeted screening for high-risk people is key, but broad population screening is still being figured out. That leads us to the actual diagnosis when a suspicious spot is found.
Right. The main goal here is to identify melanoma before it gets invasive and has a chance to spread, which is when it becomes really dangerous. The exam needs to be thorough. You have to look at the entire skin surface, including places people might miss: scalp, inside the mouth, under the nails.
Not just the sunny spots.
Definitely not. Good lighting is essential. A simple magnifying glass helps, but a dermatoscope really elevates the evaluation of pigmented spots.
Can you explain what dermoscopy adds?
Sure. A dermatoscope gives you low-level magnification, maybe 10x, and uses special lighting, either polarized or with a liquid interface on the skin. This lets you see pigment patterns and tiny blood vessel structures within the top layers of skin that you just can't see with the naked eye. The source likely has figures, maybe like Fig 76.2, showing these patterns, things like irregular networks, dots, globules, streaks that help tell benign moles apart from potentially cancerous ones.
So it helps decide biopsy or not biopsy.
Exactly. Any spot that looks suspicious clinically or shows worrying signs on dermoscopy really needs a biopsy. If the suspicion is very low, maybe document it with photos and watch it, or get a specialist opinion. But for real concern, biopsy is the way to confirm.
What's the best way to biopsy a suspicious pigmented lesion?
For any pigmented spot that's changed or just looks worrying, the ideal approach is usually an excisional biopsy. That means cutting the whole thing out with a small margin of normal skin around it, maybe 1 to 3 millimeters. This is preferred because it gives the pathologist the entire lesion to examine, allows for the most accurate measurement of thickness if it is melanoma, and it's also the definitive treatment if it turns out to be benign.
What if it's huge, or somewhere tricky like the face or a finger?
Good point. In those situations, like the face, hands, feet, where cutting out a larger piece might cause problems, an incisional biopsy taking just a representative piece is acceptable. You'd aim to get a sample from the thickest or darkest part. Importantly, studies show that doing this kind of partial biopsy correctly doesn't seem to make the melanoma spread. You just need enough tissue for diagnosis and maybe special tests.
Are there other biopsy methods, like shave or punch biopsies?
Yes, those can be alternatives, especially if the clinical suspicion isn't super high. Things like shave biopsies, saucerization, or punch biopsies. The absolute key thing with these is that the biopsy must go deep enough to get the very bottom of the lesion. The source even notes that seeing some pigment at the base of a punch biopsy is okay as long as you got the deepest part. There's a bit of a trade-off. A punch might get the depth better but miss the edges. A shave might get the width but be too shallow. You choose based on what's most likely to give the pathologist the full picture.
Okay, biopsy done. Then comes the pathology report, which is critical.
Right.
What absolutely has to be in that report?
It definitely needs to be read by a pathologist who really knows pigmented lesions. And the report must include several key pieces of information for proper diagnosis and staging. These are Breslow thickness, that's the most important prognostic factor. Mitotic rate, how fast cells are dividing, whether there's ulceration on the surface, any sign of lymphatic or vascular invasion, evidence of regression where the tumor might have partially shrunk back, presence of microsatellitosis, tiny nearby spreads seen only microscopically, and critically, the status of the surgical margins, are they clear or involved?
Let's just nail down that definition of Breslow thickness again, since it's so crucial.
Right. Breslow thickness is the measurement in millimeters taken vertically on the microscope slide. It goes from the top of the living epidermal layer, the granular layer, or from the base of the ulcer if it's ulcerated, straight down to the deepest invasive melanoma cell found. That single number is the best predictor of the risk of recurrence or spread.
What if it's a really tricky case? Hard to tell if it's melanoma or just a weird mole. Are there extra tests?
Yes, for those challenging borderline cases, there are ancillary diagnostic tools. Techniques like efflorescence, in situ hybridization, using probes for common melanoma chromosome changes, or comparative genomic hybridization can help differentiate from benign nuvi.
And the source also mentioned gene expression profiles, GEPs.
Correct. Gene expression profile, or GEP, assays have emerged as tools to help predict prognosis. The source mentions a specific 31-gene GEP test that's commercially available. It looks at the activity levels of these genes to estimate the likelihood of the melanoma coming back later, especially spreading to distant sites. It's based on gene patterns linked to progression. But, and this is really important, while this GEP gives a probability of distant relapse, it hasn't yet replaced the prognostic information we get from the standard surgical staging based on thickness, ulceration, and node status. It's seen as supplementary right now.
So it adds information, but doesn't override the basics yet.
Exactly. But the expectation is that GEPs will likely get incorporated into future melanoma guidelines as we get more data, much like they are in some other cancers, like uveal melanoma or certain breast cancers.
Okay, diagnosed it, assess prognosis. Now let's talk classification and what actually drives melanoma development, the pathogenesis.
Historically, melanomas were grouped into 5 main clinical types based on how they looked, which you can see in Table 76 too. These were lentigo-maligna, superficial spreading, nodular, acral lentiginous, and desmoplastic melanoma. The table shows typical locations, appearances, and some general genetic associations.
Can you give us a quick picture of a couple of them?
Sure, superficial spreading is the most common. It tends to grow outwards, radially, across the skin surface for a while before it goes deeper, often has irregular borders and different colors. Lentigo maligna typically shows up on chronically sun-damaged skin, like the face in older people, starts flat and spreads, maybe develops a bump later. Nodular melanoma, on the other hand, tends to grow down, vertically, right from the start. Often just looks like a dark, raised bump without that initial flat phase.
And that difference in growth, radial versus vertical, was considered important.
It was. The idea was that the types with a significant radial growth phase, superficial spreading, lentigo maligna, acral lentiginous, were spreading sideways in the top layer first, making them more curable if caught then. Nodular, growing down from the outset, was seen as inherently more aggressive early on. Desmoplastic is another type, often linked with scar tissue and nerve involvement. And melanotic melanoma is tricky because it lacks pigment.
But you said these clinical types are now mostly of historical interest and aren't used for staging. Why the change?
Yes, that's a key shift. While they look different, these visual classifications don't actually tell us much about prognosis and aren't part of the modern AJCC staging system. The real progress in understanding melanoma comes from looking at its genes and mutations. Genomic profiling is increasingly telling us about prognosis, how the tumor started, and it's directly impacting surveillance and, critically, treatment choices, especially for advanced disease.
So we're moving from classifying by appearance to classifying by the underlying genetic blueprint.
Pretty much, yes. Next-generation sequencing has just blown the lid off how complex melanoma genomes are. Whole exome sequencing shows this incredibly complicated mix of inherited and acquired mutations. In fact, cutaneous melanomas have one of the highest rates of somatic mutations those acquired during life of almost any cancer type, often more than 10 mutations per million DNA base pairs.
And that's mostly UV damage again.
Predominantly, yes. The vast majority, maybe 76% of primaries, 84% of metastases show a mutational signature characteristic of UV radiation damage. And the amount varies by location. Skin that's seen chronic sun exposure, like the face and neck, tends to have way more mutations than skin with intermittent exposure.
With potentially thousands of mutations, how do we know which ones are actually causing the cancer?
Right, that's where the idea of driver mutations comes in. Only a small fraction of all those mutations are thought to be drivers. These are the specific changes that mess up key pathways controlling things like cell growth, the cell cycle, programmed cell death, apoptosis, or DNA repair. By disrupting these pathways, they give the cell a growth advantage, pushing it towards becoming cancerous.
And these drivers interact with the inherited risk genes, like CDKN2A.
They often do. Driver mutations frequently arise in melanocytes that might already be vulnerable due to an inherited mutation, like in CDKN2A, which already weakens the cell's ability to stop dividing or die off when damaged. So you get this accumulation of UV damage and new driver mutations in a cell that's already compromised, leading to the full malignant behavior invasion, spreading, recruiting blood vessels.
Can we group melanomas based on these genetic drivers?
Yes, there's a proposed genomic classification based on which major driver genes are mutated, usually categorized by mutations in BAF, NRAS, or NF1, or being a triple wild type lacking key mutations in those three. Interestingly, the pattern of these mutations can differ depending on where the melanoma started on the body, and this genomic type is separate from the old visual classification.
And why is knowing this genomic profile so critical now?
Because it directly guides therapy, especially targeted therapy. The main growth pathways that are hit by these driver mutations are the MAP kinase pathway and the PI3 kykate pathway. RAS and BRA are key parts of that MAP kinase pathway. When they get mutated in a way that switches them permanently on, they become targets for specific inhibitor drugs.
Can you give examples of those key mutations?
Sure. NRS gets mutated in about 20% of melanomas. BIF mutations are even more common, found in most benign moles actually, but also in 40–50% of cutaneous melanomas. Though it seems having just an NRAS or BRAF mutation isn't enough by itself, they often happen along with other changes like mutations in the TERT gene promoter, which is involved in cell immortality. The most frequent BRAF mutation by far is a specific one called V600E. It's more common in younger patients and on skin with intermittent sun exposure. Less common in the chronically sun-damaged skin of older patients where you might see more NRS mutations or other drivers.
And the other pathway, PI3KKT.
That one gets hit too. Mutations in AKT itself or in PIK3CA can switch on this pathway, which basically helps cells survive by blocking apoptosis or programmed cell death. Loss-of-function mutations in NF1, seen in 10–15% of melanomas, can actually affect both the MET kinase and PI3KT pathways. So bottom line, disrupting these two pathways, MET kinase and PI3KKT, is really central to how melanoma develops and progresses. They boost growth, resistance, movement, and uncontrolled division.
The source includes a diagram, figure 76-3, showing these development pathways. Can you describe what that illustrates?
Yeah, that figure gives a nice visual hypothesis. It suggests two main routes melanoma might take. One is the chronic sun damage pathway, typical in older folks on sun-beaten skin. It might progress from a lentigo maligna in situ to invasive melanoma, often driven by NRAS or maybe other mutations. The second route is shown starting either fresh, de novo, or from an existing mole. This pathway involves steps from a benign mole through atypical stages to melanoma in situ and then invasive melanoma like superficial spreading or nodular types. This route is more often linked with BRAF mutations, especially V600E, and perhaps intermittent sun exposure. The diagram helps connect the different genetic drivers to these potential development tracks.
That really links the genetics to what we see clinically. Building on that, how do we predict how a melanoma is likely to behave? What are the key prognostic factors?
The most critical factors for predicting outcome are the ones used in staging. The single best predictor of recurrence and survival for a primary melanoma is its Breslow thickness. The second most important is whether or not there's ulceration present on the surface. Those two features, thickness and ulceration, are combined to determine the T stage in the AJCC system.
Does where the melanoma is on the body matter?
Yes, the location is an independent prognostic factor. Some sites are considered more favorable, linked to better outcomes like the forearm and leg. Unfavorable sites linked to worse prognosis include the scalp, hands, feet, and mucous membranes.
And is there a difference between men and women?
Generally, yes. Women with localized or regional disease, stage 1 or 2, tend to have better survival rates than men with similar stage disease. This might partly be because women often get melanomas on the lower leg, which is a favorable site, and maybe they detect them earlier too. Older individuals, especially men over 60, face some extra challenges. They're more likely to be diagnosed later with thicker tumors. They also get more melanomas on the head, neck, and acral sites, those unfavorable locations prone to earlier vertical growth and spread. Plus, melanomas on their chronically sun-damaged skin are often BRAF wild type, which historically limited targeted therapy options, although immunotherapy has changed that landscape significantly.
What else in the pathology report signals a worse prognosis?
Other important bad signs seen under the microscope include a high mitotic rate, lots of dividing cells, evidence of microscopic regression, where parts of the tumor seem to have been destroyed by the immune system, paradoxically linked to worse outcome, and any sign of lymphatic or vascular invasion tumor cells getting into vessels. Clinically, finding microsatellite lesions or in-transit metastases near the primary site, having obviously enlarged lymph nodes, or having an elevated blood level of lactate dehydrogenase, LDH, all point to more advanced disease and worse prognosis. And of course, the presence and location of distant metastases are defined by the M stage.
And you mentioned GEPs help predict prognosis too.
That's right. Gene expression profiling and machine learning using genomic and clinical data are being used to estimate prognosis. That 31-gene GEP assay we talked about gives a probability of distant relapse based on gene activity patterns. But it bears repeating, right now it predicts risk, but hasn't replaced the prognostic estimates we get from the standard surgical staging. We expect it'll be integrated more formally into guidelines down the road.
Okay, so we diagnose, assess prognosis, and then stage it. How does the staging system work for melanoma?
Staging is absolutely fundamental. It does two key things. Tells us the patient's likely outcome, prognosis, and helps guide treatment decisions. Table 76-3 lays out the current AJCC staging criteria. It uses the TNM system tumor characteristics, thickness, ulceration, node involvement, regional lymph nodes, and metastasis, distant spread, to define stages from 0 through 5V, and gives estimated survival rates for each.
And you mentioned clinical versus pathologic staging.
Correct. Clinical stage is based on the initial biopsy results, giving the T stage, plus what the doctor finds on physical exam and maybe initial scans of lymph nodes and distant sites. Pathologic stage is more definitive. It includes microscopic examination of lymph nodes that felt normal clinically, usually via that sentinel lymph node biopsy, plus examination of any nodes that were enlarged, and biopsy confirmation of any suspected distant spread.
So what's the initial workup for a patient newly diagnosed with melanoma?
First, a thorough history. You need to ask about any symptoms that might hint at spread new lumps, feeling unwell, losing weight, headaches, vision problems, bowel changes, coughing blood, pain. Then a careful physical exam looking for any leftover tumor at the biopsy site, any bumps in or under the skin nearby, satellite and transit mets, and checking all the lymph node areas.
What about blood tests or scans?
Standard labs include a complete blood count, metabolic panel, and LDH level. These aren't great at finding hidden mets in early-stage patients without symptoms, but abnormalities can be clues. For example, anemia might suggest spread to the bowel. High liver enzymes could mean liver mets, and that elevated LDH is a specific adverse factor used in stage 5 classification. If labs are off or the patient has symptoms, then imaging like CT or PET scans is definitely needed.
Should everyone with melanoma get scans?
No, generally not, and the source emphasizes this. For the majority, maybe over 80% who have localized disease, stage 3, and no worrying symptoms or exam findings, routine imaging isn't recommended. The chance of finding distant mets is just too low. There's maybe a slight exception debated for very high-risk primary tumors, say over 4 millimeters thick with ulceration, where the chance of hidden mets might be higher than the chance of a positive sentinel node. In those specific cases, upfront imaging might be considered.
Okay, staging sets the map. That leads to treatment, starting with localized and regional disease stages first, 2 and 3.
Right. For clinically localized melanoma, stage 1 and stage 2, the main treatment is surgery, a wide surgical excision of the original tumor site. The goal is simple but vital. Get all the cancer cells out, along with a safety margin of normal skin around it to prevent it from coming back right there.
What are the standard margins for that excision?
The NCCN guidelines, based on clinical trials, give specific recommendations depending on the melanoma's thickness. For melanoma in situ, it's usually 0.5 to 1.0 centimeters. For invasive tumors, up to 1 millimeter thick, 1 centimeter margin. Between 1.01 and 2 millimeter thick, 1 to 2 centimeters. And for anything over 2 millimeter thick, a 2 centimeter margin.
Can you always take those margins, say, on the face?
Not always practical or desirable. In sensitive spots like the face, hands, feet, genitals, surgeons might use narrower margins to preserve function or appearance, understanding there might be a slightly higher risk of local recurrence. But regardless of the width, the specimen always needs to include the subcutaneous fat layer underneath so the pathologist can measure thickness accurately and check the deep margin. The cut usually goes down to the fascia, the tough layer over muscle. For very thick T4 tumors, they might even remove the fascia.
Any non-surgical options for the primary site?
Well, for lentigo maligna, that specific type of melanoma in situ, often on the face, topical imiquimod cream can sometimes be used, maybe after surgery, with narrow margins. It boosts the local immune response to mop up any remaining microscopic cells and cut recurrence risk.
You mentioned sentinel lymph node biopsy for staging. Does it influence treatment for stage 1 and 2?
Yes, while primarily a staging tool for prognosis, the result directly impacts subsequent treatment decisions, especially moving into stage 3 territory. SLNB is done for patients whose primary melanoma has a significant risk of having already spread microscopically to nearby lymph nodes. It helps identify those at higher risk of relapse who might benefit from additional systemic therapy after surgery, known as adjuvant therapy.
How's that procedure actually done?
They inject a blue dye and a tiny amount of radioactive tracer near the original melanoma site. Then, using a handheld gamma probe, the surgeon tracks where that tracer flows in the lymphatic system to find the first one or few lymph nodes it drains to. Those are the sentinel nodes. They look for nodes that are radioactive hot or stained blue, remove them through a small incision, and send them to pathology. Pathologists then slice these nodes very thinly and examine them carefully with stains like H&E and special markers S100, HMB45, MART1, Milana to hunt for any tiny melanoma cells.
Who actually needs an SLNB based on current thinking?
NCCN guidelines usually recommend it if the risk of finding cancer in the node is about 10% or higher. That typically means primary melanomas thicker than 1 millimeter, T1b or greater. It's also considered for intermediate risk, maybe 5–10%, like tumors between 0.75 and 1.0 millimeter thick, or if the initial biopsy cut through the tumor, or if there was regression or lymphovascular invasion seen. But it's generally not recommended if the risk is thought to be 5% or less, typically for thin melanomas, AR 0.75 millimeters, without any other high-risk signs. For those patients, the wide excision alone is usually considered enough.
What happens based on the SLNB result?
If it's negative, no cancer cells found, patients are usually just monitored. If they had a very high-risk primary tumor, stage I, B, or IC, they might be eligible for clinical trials looking at adjuvant therapy in that specific group.
And if it's positive?
A positive SLNB means microscopic spread to the nodes, making it stage 3 disease. First step then is imaging CT or PET scan to make sure there's no spread elsewhere in the body. Distant mets. If imaging is clear, confirming stage 3, then the patient should be offered adjuvant systemic therapy to reduce the risk of future recurrence.
What about taking out all the rest of the lymph nodes in that area? Completion lymphadenectomy, that used to be routine, right?
It absolutely used to be standard. But major trials showed that while removing all the nodes after a positive sentinel node does prevent cancer from coming back in that specific node basin, improves relapse-free survival, it doesn't actually help patients live longer overall. And since that bigger surgery has significant side effects, like chronic arm or leg swelling, lymphedema, it's no longer routinely recommended just for a positive SLNB.
So what's done instead of that big node surgery?
The main alternative is active surveillance of that lymph node basin. This means regular checkups with physical exam and ultrasound imaging, maybe every 4 to 6 months for a few years, to catch any progression in the nodes early if it happens. Completion dissection is still an option sometimes, maybe for patients who can't reliably do the follow-up or who choose not to have adjuvant therapy.
Okay, let's talk more about stage 3. What else puts someone in that category besides a positive SLNB?
Stage 3 also includes patients who have lymph nodes that were clearly enlarged and cancerous on exam or scans and were surgically removed, macrometastases. It also covers patients who have resected locoregional disease, meaning recurrences that pop up near the original scar, satellite lesions if close within 2 centimeters, or further along the lymphatic drainage path, but not yet in the nodes, in transit metastases if more than 2 centimeters away.
And even if you cut all that out, the risk of it spreading further is still high.
Yes, definitely. Even after completely removing all visible stage 3 disease, the risk of it later showing up as distant metastases, stage 4, is significant. That's why adjuvant systemic therapy is now considered standard of care for these patients. Recurrence can happen right at the scar as these satellite or in-transit spots, or most commonly as new spread to regional lymph nodes.
How are those regional recurrences handled if they appear?
Surgery to remove them is the main approach, if feasible. And increasingly, that surgery is followed by adjuvant systemic therapy, immunotherapy, or targeted therapy if they have the BRAF mutation. This combination gives the best shot at long-term control. For small skin-only recurrences, topical imiquimod might help, and there's that injectable oncolytic virus, talumagene liaparvec, TVEC, which can be used for skin, subcutaneous, or nodal deposits that can't be easily cut out.
So who gets adjuvant systemic therapy overall?
Primarily patients with completely resected stage 3 melanoma, but it's also considered for some high-risk node-negative patients, stage IB-IC thick or ulcerated primaries, and even for patients who had stage 4 disease that was completely removed surgically.
What are the main adjuvant drugs used now?
The current go-to options are anti-PD-1 immunotherapy nivolumab or pembrolizumab, or for patients whose tumors have a BRAF V600 mutation, combination targeted therapy with a BIF inhibitor plus a IC inhibitor. Both have clearly shown they improve disease-free survival and overall survival compared to older options like high-dose interferon or ipilimumab alone, which are used much less now due to lower effectiveness or higher toxicity. There's also a lot of research looking at giving systemic therapy before surgery, neoadjuvant, versus after, and figuring out the best sequence of immunotherapy and targeted therapy for BRAF-mutated patients. And maybe GEPs will eventually help us identify lower-risk stage 3 patients who could safely skip adjuvant therapy.
So the treatment even for regional disease has been totally transformed. Now let's shift to the toughest scenario. Metastatic disease, stage 4.
Right. Only about 4% of people have metastases when they're first diagnosed, but many others, especially those starting with higher risk stage 2 or 3rd, will unfortunately develop distant spread later on. The chance of that happening really depends on the initial stage, very low for stage IA, but can be over 90% for some stage subsets.
So if someone with a history of melanoma gets new symptoms, assume recurrence until proven otherwise.
Pretty much. Any new concerning symptoms in a melanoma survivor warrant a full restaging workup history, exam, labs including LDH, and usually scans like CT or PET.
Where does melanoma typically spread?
Common sites for distant mets are skin, distant lymph nodes, lungs, liver, gastrointestinal tract, bone, and the brain. And the prognosis in stage 3 really varies depending on where it has spread. This is captured by the M stage.
Yeah.
Skin subcutaneous mets, M1A, tend to have a better outlook than lung mets, M1B, which are better than mets in other organs like liver, bone, or GI tract, M1C, or the brain, M1D. And having that elevated LDH level is a strong negative sign. It automatically puts you in M1C, regardless of where the mets actually are.
But you mentioned earlier that survival in stage V has improved dramatically.
It really is one of the biggest success stories in oncology recently. Before about 2010, maybe fewer than 10% of patients with metastatic melanoma lived 15 years. Now, thanks to targeted therapy and immunotherapy, that overall figure is over 25%. The benefit is clearest for M1A and M1B, but even M1C patients are living longer. There's data suggesting if someone is progression-free for more than 2 years on therapy, they have a very good chance of living more than 5 years from when the mets were found.
That's truly incredible progress in just over a decade. What are the specific drugs responsible for this?
The whole landscape changed starting around 2011. Table 76-4 lists the key players. We have immune checkpoint inhibitors. Anti-CTLA-4, ipilimumab, anti-PD-1, nivolumab, pembrolizumab, and the combination, EP plus Nivo. Then, for patients with the right mutation, oral targeted drugs hitting the MAP kinase pathway. BRAF inhibitors, vemurafenib, dabrafenib, encorafenib, and MEK inhibitors, trametinib, cobimetinib, binimetinib, plus the oncolytic virus TVEC we mentioned.
Does surgery or radiation still play a role in stage 4?
Yes, definitely in some situations, especially for what's called oligometastatic disease, where there are only a few spots of spread. In selected patients, completely removing those mets surgically, metastasectomy, or destroying them with highly focused radiation, stereotactic radiosurgery, can lead to long-term survival, maybe even cure. Best candidates usually have just one metastasis, but it can be considered for multiple sites if they can all be treated safely. Patients treated this way are still at high risk for more mets later, so they might get adjuvant therapy or join a trial. Surgery can also be an adjunct, like removing a resistant spot, while systemic therapy controls the rest.
If it comes back or spreads, do you need to retest the tumor's genes?
Often, yes. Getting a biopsy of a new metastasis might be needed, especially if the original tumor wasn't tested or if resistance is suspected. Knowing the current BRAF or c-KIT mutation status is crucial for guiding targeted therapy choices.
So for a patient newly diagnosed with metastatic melanoma, what's the first step in planning treatment?
The absolute critical first step is molecular testing of the tumor, ideally from a metastatic site, to check for mutations, primarily BRAF V600 mutations, but also maybe KIT mutations depending on the melanoma type. The initial treatment strategy really hinges on that BRAF status.
How does that status guide the choice?
If the tumor is BRAF wild type, no mutation, then immunotherapy is the recommended first-line approach, usually anti-PD-1 alone or the ipi-nivo combination. If the tumor does have a BRAF mutation, then either combination BRAF plus ME inhibitors or immunotherapy are both considered acceptable initial options.
How do you choose between targeted therapy and immunotherapy if the tumor is BRAF mutated?
Well, if the disease is growing very fast, causing a lot of symptoms, or there's a high tumor burden, the combination BRAF/MEK inhibitors are often preferred first because they tend to work faster and cause more dramatic shrinkage. But for patients with less aggressive, minimally symptomatic BRAF mutated disease, the best sequence immunotherapy first versus targeted therapy first isn't totally clear yet. That's being studied in big clinical trials right now.
Despite all this progress, is stage 4 melanoma curable for most patients now?
Unfortunately, no. While treatments are much better and survival is longer, the reality is that most patients with stage 4 melanoma are still not cured with today's therapies. That's why clinical trials are so important for advanced disease, offering access to potentially better treatments, even as a first option. Trials are also the main path forward if the standard therapies stop working. And we also have to remember, sadly, that some patients might not be suitable for aggressive treatment due to extensive disease, poor health, or other illnesses. For them, integrating palliative care and hospice early is essential for focusing on comfort and quality of life.
Thank you. That's a really clear picture of stage 4. It's amazing how much has changed. Let's spend a bit more time unpacking how these powerful new systemic therapies actually work, starting with immunotherapy.
Right. Immunotherapy, especially these checkpoint inhibitors, basically works by taking the brakes off the patient's own immune system so it can attack the cancer. Our immune system has natural checkpoints inhibitory receptors like CTLA4 and PD-1 on T cells. They're normally crucial to stop the immune system from going overboard and attacking healthy tissue after an infection is cleared, for example.
But in cancer, these breaks can be a problem.
Exactly. When T cells are constantly seeing tumor antigens, these checkpoints can get stuck in the on position. This leads to the T cells becoming exhausted. They just can't function properly anymore to kill the cancer cells. Checkpoint blockade therapy uses antibodies that physically block these CTLA4 or PD-1 receptors. This releases the brakes, wakes the T cells back up, and allows them to go after the tumor again. We saw this work beautifully in animal models first.
And ipilimumab, targeting CTLA4, was the first real proof in humans.
Yes, ipilimumab was the first drug of this type to show an actual survival benefit in a randomized trial for metastatic melanoma. The response rates weren't super high, maybe 10%, but it proved the concept blocking a checkpoint could lead to durable responses and longer survival for some.
How did the PD-1 blockers improve on that?
The PD-1-PD-L1 pathway is another key break. PD-1 is on the T cell, and its partner, PD-L1, can be expressed by tumor cells to protect themselves. Blocking this interaction, either with anti-PD-1 drugs like nivolumab and pembrolizumab, or anti-PD-L1 drugs, turned out to be even more effective for many patients. It leads to higher response rates, potentially cures in some, and generally, PD-1 blockade alone has fewer severe side effects than CTLA4 blockade alone.
And hitting both pathways at once, the combination.
Combining them, typically ipilimumab anti-CTLA4 plus nivolumab anti-PD-1 gives even better anti-tumor activity than either one alone. The standard combo regimen involves several initial doses of both drugs, followed by nivolumab maintenance. This approach got response rates up around 56% and clearly improved survival compared to ipilimumab by itself.
Can we predict who will respond best?
That's still the million-dollar question. Early on, people looked at PD-L1 expression on the tumor, thinking higher expression might mean better response to anti-PD-1. But it hasn't turned out to be a perfect biomarker in melanoma. Plenty of patients with low or no PD-L1 expression still get great lasting responses. So it's useful information, but not definitive for selection.
What about the side effects? Taking the brakes off the immune system sounds risky.
It absolutely can be. Because you're interfering with normal immune regulation, the immune system can sometimes start attacking healthy tissues. These are the immune-related adverse events, or IRAEs. They can affect almost any organ. The most common things we see are skin rashes and diarrhea, which can sometimes progress to severe colitis.
And other organs, too.
Yes, you can get inflammation of the thyroid, pituitary gland, liver, kidneys, lungs, heart, nerves, pretty much anywhere. The risk and severity are generally highest with the combination therapy, then anti-CTLA4 alone, and lowest with anti-PD-1 alone.
How are these managed?
The key is recognizing them early. Management often involves pausing the immunotherapy and using immunosuppressants, primarily steroids, but sometimes stronger drugs like anti-TNF antibodies or mycophenolate if needed to calm the immune system down. Importantly, treating these side effects with immunosuppressants doesn't seem to cancel out the anti-cancer benefit of the immunotherapy. The effect can still be durable, even if treatment has to be stopped due to toxicity.
So despite the potential side effects, these checkpoint drugs are now standard for metastatic melanoma.
Absolutely. They're a cornerstone of treatment. There's still debate about whether everyone needs the combination or if single-agent anti-PD-1 is enough for some, balancing efficacy and toxicity. And of course, these drugs are very expensive, which is a real factor.
Okay, let's switch gears to the other major advance, targeted therapy. What pathways are these drugs hitting?
Targeted therapy in melanoma mainly goes after the Ayers-RAF-MEK-ERK pathway, which is often just called the MAP kinase pathway. This is a key signaling chain inside cells that tells them to grow and survive. It gets abnormally switched on by driver mutations in about half of cutaneous melanomas, usually mutations in BRAF or NRS.
And the drugs block this faulty signaling.
Exactly. For melanomas with those specific activating BRAF mutations, especially the V600 type, drugs that inhibit the mutated BRAF protein can shut down that hyperactive signal. Likewise, drugs inhibiting MEK, which is further down the chain, can also block it. These inhibitors can cause really rapid and dramatic tumor shrinkage in patients with the right mutation.
Which BRAF drugs are used?
The main FDA-approved ones are vemurafenib, dabrafenib, and encorafenib, all for BRAF V600 mutated stage Phi melanoma.
You mentioned earlier that using just a BRAF inhibitor alone was replaced by combination therapy. Why combine them?
This was driven by understanding how resistance develops. When you used a BRAF inhibitor alone, the cancer cells often figured out ways to reactivate the MAP kinase pathway pretty quickly, leading to relapse. Combining a BRAF inhibitor with a MEK inhibitor provides a more complete shutdown of the pathway and makes it harder for the cells to find bypass routes, delaying or preventing resistance.
And the combination works better.
Yes. Big clinical trials clearly showed that combining a BRAF inhibitor with a MEK inhibitor, like dabrafenib plus trometinib, vemurafenib plus cobimetinib, or encorafenib plus binimetinib, led to significantly better progression-free survival and overall survival compared to using the BRAF inhibitor alone.
But resistance is still the main problem with targeted therapy.
Unfortunately, yes, it's the major limitation. While some patients get long periods of control, most eventually relapse because the tumor adapts and finds ways around the blockade, often by reactivating that same MAPK pathway through different means. When resistance develops, patients are usually then considered for immunotherapy or clinical trials.
What are the side effects like for targeted therapy? Different from immunotherapy?
Yes, a different profile, generally manageable, but distinct from chemo or immunotherapy. One really unique side effect seen with BRAF inhibitor monotherapy was the development of new skin growths, including actual squamous cell skin cancers, SCCs, or related lesions called keratoacanthomas, in up to a quarter of patients.
That sounds totally backwards, a drug for one skin cancer causing another.
It was surprising. The mechanism is called paradoxical activation. In cells that don't have the BRAF mutation, wild-type cells, the BRAF inhibitor drug can actually activate the MAP kinase pathway instead of blocking it. This stimulates normal skin cells to grow, forming these lesions. Crucially, this paradoxical effect is blocked by MEK inhibitors. That's why you see far fewer of these secondary skin cancers when patients get the combination BF-MEK therapy. These treatment-induced SCCs don't seem to spread, and usually you can just remove them and continue the targeted therapy safely. Other less common but potentially serious side effects like heart or eye issues can also occur and need monitoring.
Are there targeted therapies for other mutations, like c-KIT or NRAS?
c-KIT mutations are less common in typical cutaneous melanoma, but more frequent in mucosal and acral types. When present, these mutations can sometimes respond to drugs like imatinib, which is used for GIST tumors with similar mutations. Response rates are maybe around 29%. NRAS mutations occur in 15-20% of melanomas. Unfortunately, despite activating the same pathway, we don't yet have effective, approved, targeted drugs specifically for NRAS-mutated melanoma, although inhibitors are being tested in trials.
Any other systemic options left for stage 4?
High-dose interleukin-2, IL-2, is an older immunotherapy that can lead to very durable remissions in a small, select group, but it's quite toxic and used much less now. Traditional chemo like dacarbazine or taxanes is also rarely used first-line anymore, given the better options. Clinical trials remain a really important avenue for advanced melanoma patients at all stages of treatment.
With all these treatments and the risk of recurrence, what does long-term follow-up look like for someone who's had melanoma?
Generally, anyone who's had melanoma, regardless of the stage, should have a skin check by a healthcare provider at least once a year for life. The risk of getting a second primary melanoma or having the first one recur is significantly increased.
Do they need routine scans or blood tests forever?
No, not usually for early stages. For patients initially diagnosed with stage IA or IIA who had surgery, routine blood work or scans like CTP are not recommended unless they develop new symptoms concerning for recurrence. Surveillance imaging might be considered for high-risk stage 3 patients, but it's mainly used if there are signs or symptoms of recurrence or to monitor response during active treatment. The NCCN guidelines provide detailed stage-specific recommendations for follow-up schedules.
Okay, we have gone incredibly deep into melanoma origins, risk, genes, diagnosis, staging, and the revolutionary treatments. But as the source makes clear, melanoma isn't the whole story. Let's shift now to non-melanoma skin cancers, NMSCs.
Right. NMSCs are actually by far the most common cancers in the U.S. They mostly break down into basal cell carcinomas, BCCs, and squamous cell carcinomas, SCCs.
Way more common than melanoma, you said.
Oh, significantly.
Sorry.
We don't have perfect registry data everywhere for NMSCs, but estimates are over 5.3 million cases diagnosed each year in the U.S. alone. SCCs make up the bulk, maybe 80%, with BCCs around 18%.
What about Merkel cell carcinoma? You mentioned that one earlier.
Yes, Merkel cell carcinoma, MCC, is less common but definitely important. Worryingly, its incidence has tripled over the last 20 years or so. We're seeing maybe 1,600 new cases a year in the U.S. now, and it's increasing by about 8% annually.
Can these NMSCs spread, like melanoma can?
Yes, they all have the potential, though the frequency varies a lot. MCC is the most likely to metastasize. The rate of spread to sentinel lymph nodes is around 25%, which is actually higher than we typically see in melanoma. And MCC has a pretty high mortality rate, approaching 33% within 3 years. SCCs, especially ones with high-risk features, can also metastasize, mostly to regional lymph nodes. They're estimated to cause about 2,400 deaths per year in the U.S.
So while BCCs are numerous and often less dangerous, SCCs and MCCs can be serious threats. What's the main cause of NMSCs? Still UV.
Primarily, yes. Just like melanoma, ultraviolet radiation is the #1 culprit, and it's dose-dependent. Even just a few tanning bed sessions a year increases risk, maybe 15% for BCC, 11% for SCC for just 4 visits annually.
Any other factors involved?
Yes, definitely. Smoking is linked to SCC of the lip and mouth, which tend to be worse. HPV might act as a cofactor with UV in some cases. And inherited conditions where DNA repair is faulty, like xeroderma pigmentosum, lead to massive increases in skin cancer, really proving that link between UV damage, failed repair, and cancer development.
How does that UV damage actually cause the genetic changes that drive NMSCs?
In SCCs, UV often damages key genes like the tumor suppressor p53 or oncogenes like NRAS. In BCCs, the damage frequently hits genes in the hedgehog signaling pathway. This pathway normally controls basal cell growth, but when damaged, it leads to uncontrolled proliferation. Specifically, the most common hit in BCC is losing function of a gene called PTCH1. PTCH1 normally keeps another protein, SMO, inhibited. When PTCH1 is broken, SMO becomes constantly active, driving the BCC growth.
So that hedgehog pathway is central to BCC. Any targeted drugs for that?
Absolutely. Because it's so key, there are 2 FDA-approved oral drugs, Vismodegib and Sonidegib, that directly inhibit SMO. They're used for advanced BCC that can't be treated with surgery or radiation. And genetic syndromes like Gorlin syndrome, caused by inherited PTCH1 mutations leading to hundreds of BCCs, further confirms how vital that pathway is for BCC development.
Immunosuppression was a risk for melanoma. Is a big factor for NMSCs too?
Oh, huge. Immunosuppression is very strongly linked to NMSCs and often makes them more aggressive. Organ transplant recipients who are on long-term immunosuppression have a massive increase in risk, like 65 times the risk for SCC, 10 times for BCC. The risk depends on how suppressed they are, for how long, and their sun exposure history. And SCCs in these patients are notoriously aggressive, more likely to recur, spread, and be fatal. Some data also suggest TNF blockers used for autoimmune diseases might increase NMSC risk too.
Any other major risk factors for NMSCs?
Yeah, things like HIV infection, prior radiation therapy, old burn scars, chronic non-healing ulcers, and as we discussed, those SCCs that pop up during BRAF inhibitor therapy for melanoma. Plus, there's a list of specific genetic syndromes that predispose people to NMSCs albinism, XP, Muir-Torrey, Gorlin syndrome, and several others.
What about the cause of Merkel cell carcinoma? You mentioned a virus.
Right. MCC is linked to UV, age, and immunosuppression like the others, but it also has a strong viral connection. About 80% of MCC tumors contain DNA from the Merkel cell polyomar virus, MCPYV. It seems to be an oncogenic virus. In those virus-positive tumors, a viral protein called large T antigen interferes with crucial tumor suppressors, p53 and RB, driving the cancer. So while UV and immunity play roles, the virus is a key factor in most MCCs. Patients often have immune responses to the virus, but sadly, it's usually not enough to control the cancer.
So a real mix of UV genes, immunity, even viruses. How do these different types actually look on the skin?
Let's start with basal cell, BCC. These come from the basal layer of the epidermis. The least aggressive is superficial BCC, often just subtle pink or reddish scaling patches that grow slowly. Common on the trunk or limbs, sometimes mistaken for eczema or psoriasis. More common is nodular BCC, that's the classic small, slow-growing bump. Often looks pearly or translucent, has tiny visible blood vessels, telangiectasias, and maybe rolled edges with a central crust or dip. Figure 76.4a probably shows this, and 76.4b might show dermoscopy features.
In pigmented BCC.
That's basically a nodular BCC that happens to have melanin pigment in it, so it looks brown or black, which can definitely make you think of melanoma sometimes.
What about the more concerning subtypes?
The morphiform or fibrosing, infiltrative, and micronodular types are more invasive locally. They often look like flat or slightly sunken, firm, scar-like patches, maybe whitish, yellowish, or pinkish. The borders can be really fuzzy and hard to see, leading to treatment delays, and they often spread much further under the surface than you'd guess just by looking. The old term rodent ulcer hinted at their potential for local destruction.
Okay, moving to squamous cell carcinoma. SCC. What's its appearance?
SCC comes from the keratin-producing cells higher up in the epidermis. It's more variable than BCC and definitely has metastatic potential. It often shows up as a reddish nodule that's ulcerated or crusted, or maybe a shallow erosion, common on sun-exposed head, neck, trunk, arms, legs. But it can also look less dramatic, just a firm bump or a rough plaque, sometimes mistaken for a wart.
Any clues on dermoscopy?
Yes, dermoscopy often shows characteristic dotted or coiled blood vessels in SCC. Clinically, the edges might be hard to define, and it might feel stuck or tethered to deeper tissues.
And keratoconthoma, Ka.
Ka is a specific type of SCC known for growing really fast. Typically looks like a dome-shaped bump with a central plug of keratin, like a little volcano. Some might shrink on their own, but we usually treat them like SCCs because they can progress, and it's hard to be sure which ones will regress. These are the kind you can see with BRAF inhibitor therapy too.
What about the pre-malignant stages of SCC?
Right, actinic keratosis, AKs, those rough scaly spots on sun-exposed skin are precursors. Same for actinic cheilitis on the lid. A certain percentage of untreated AKs will eventually turn into invasive SCC, so treating them is prevention. Then there's SCC in situ, also called Bowen's disease. That's cancer confined to the top layer, the epidermis. Looks like a persistent scaling reddish patch. Usually on sun-damaged skin, but can occur anywhere, sometimes linked to HPV in non-sun-exposed areas. Treating AKOs and Bowen's is key to stopping invasive SCC before it starts.
Lastly, Merkel cell carcinoma. How does that one present?
MCC comes from neuroendocrine cells in the skin. It often looks like a raised bump or nodule, maybe flesh-colored, reddish, or purplish-blue. Size varies, but they're known for growing fast. Most common on sun-exposed areas, but can pop up elsewhere. There's a handy acronym, AEIOU, for typical features. Asymptomatic, expands rapidly, linked to immune suppression, usually in people older than 50, on UV-exposed skin. Diagnosis relies on microscopy and neuroendocrine markers. Unlike some neuroendocrine tumors, they don't secrete hormones.
Recognizing these is step one. How do they typically behave over time if not treated? Their natural history.
Basal cell, BCC, usually grows slowly but invades locally. How much destruction it causes depends on size, location, subtype, how long it's been there. Central face, ears, scalp might be high-risk locations. Nodular and superficial types are usually less aggressive locally than the infiltrative or morphiiform ones. Metastasis from BCC is extremely rare in people with normal immune systems, like 0.1%. But the risk of getting another BCC or SCC later is high, maybe 40% chance over 5 years.
So mostly local trouble and risk of more. What about squamous cell?
SCC is more variable, depends on the tumor, size, depth, how abnormal cells look, and the patient immune status. SCCs on sun-damaged skin tend to be less likely to spread than those on non-sun-exposed skin or arising in scars. Overall metastatic rate is maybe 0.3% to 5.2%, mostly going to nearby lymph nodes first. High-risk spots for spread include the lower lip, around 13%, and the ear, around 11%. SCCs from scars, chronic ulcers, or genitals also spread more often. And if an SCC comes back after treatment, its chance of spreading jumps up to about 30%. Aggressive features include being large, deep, poorly differentiated, invading nerves or lymphatics, or arising in an immunosuppressed person.
And Merkel cell. Aggressive from the start.
Yes, MCC is known for being aggressive and spreading early, kind of like small cell lung cancer behaves. It readily goes to lymph nodes and distant sites. Survival really depends on stage. Localized disease, maybe 90% cure. Nodal spread, survival drops to around 52%. Distant mets, survival is poor, maybe 10%. It has its own TNM staging. Factors predicting outcome besides stage include presence of the virus better, RB protein better, lots of T cells in the tumor better, versus things like P63 expression, worse, lymphovascular invasion, worse, and immunosuppression.
Quite a range of behaviors. How are these different NMSCs treated? Let's start with BCC.
For BCC, there are lots of effective options, things like scraping and burning, EDNC, simple surgical excision, freezing, cryosurgery, radiation, lasers, Mohs surgery, topical creams like 5-fluorosil or imiquimod, and photodynamic therapy, PDT.
How do you pick the right one?
It depends on the tumor size, type, location, and the patient, plus cosmetic considerations. EDNC is common for small, simple BCCs in low-risk areas. Standard surgical excision is used for more invasive types or when EDNC isn't suitable.
What about Mohs surgery for BCC?
Mohs is great for BCCs, especially recurrent ones, those in tricky spots like the face where you want to save tissue or aggressive subtypes. It involves taking thin layers and checking margins under the microscope immediately, ensuring complete removal while sparing normal skin. Cure rates are very high, over 98%. Radiation is an option for non-surgical candidates or as an add-on for high-risk tumors. Topical creams are mostly for superficial BCCs. PDT and injections are less common options.
And if BCC becomes advanced?
For metastatic or locally advanced BCC that can't be treated locally anymore, that's where the systemic SMO inhibitors, vismodegib and sinitegib, come in. They don't usually cure it, but shrink tumors in about half of patients, providing control often for over 9 months.
What about treating squamous cell carcinoma?
Surgical principles are similar excision or Mohs, depending on risk factors. For advanced SCC, treatment has really changed. Older options were chemo or drugs like cetuximab, but results weren't great. Now, the standard is immunotherapy with sumaplamab, an anti-PD-1 antibody. It shrinks tumors in nearly half of patients with advanced SCC, which is a huge improvement, and those SCCs caused by BRAF drugs. Just excise them, the BRAF therapy can usually continue.
Finally, Merkel cell carcinoma treatment.
MCC treatment borrows from melanoma and NMSC strategies, increasingly using immunotherapy. Early stage is often wide excision plus sentinel node biopsy, which can be curative. MCC is also sensitive to radiation, like small cell lung cancer. So radiation is often used after surgery, both to the primary site and the node basin if positive. This sometimes allows for smaller surgical margins initially. Completion node dissection for a positive sentinel node is done less often now. Adjuvant radiation or observation trials are preferred.
And for metastatic MCC?
Immunotherapy is now the go-to, replacing chemo. Avulimab, an anti-PD-L1 drug, showed responses in about a third of advanced MCC patients, and most of those responses were durable.
How do you follow MCC patients?
Follow-up depends on stage and risk. Includes regular skin checks, often by a specialist familiar with MCC, and checking the lymph node areas. That viral antibody titer we mentioned can be a useful blood test marker to track for recurrence in patients who are initially positive. A rising titer might signal recurrence even before it's visible.
Prevention is vital for all skin cancers, mostly sun protection. Any NMSC-specific prevention tactics?
Yes, beyond general sun safety. For very high-risk people, like transplant patients, active surveillance is key. Chemoprophylaxis with oral retinoids or lowering immunosuppression if possible can help manage patients with numerous tumors. Field therapy treating large areas of sun damage with creams like 5-FU or Micbod can reduce the number of AKs turning into SCC. For high-risk patients, minimizing UV is crucial, and biopsying suspicious lesions early is important for catching aggressive ones sooner.
Lastly, the source mentions other, rarer non-melanoma skin cancers briefly. Examples.
Right, these make up maybe 1-2%. Includes cancers arising from skin glands or hair follicles, adnexal neoplasms, and various skin sarcomas, fibrous, vascular, etc. Figure 76 likely shows some. Cutaneous lymphomas, B or T-cell cancer starting in the skin, like mycosis fungoides, can mimic eczema or psoriasis. Extramammary Paget's disease is a rare cancer of apocrine origin, usually seen as red patches in genital or axillary areas of older adults. Surgery, often Mohs, is key. Dermatofibrosarcoma protuberans, DFSP, is another rare tumor known for spreading widely under the skin, best treated with Mohs. And Kaposi sarcoma, linked to HHV8, became much less common with effective HIV treatment.
Wow. We have really journeyed through an immense amount of detail, pulling heavily from Chapter 76.
We certainly have. From melanoma's origins, the complex web of risk factors, genetics, UV, through diagnosis staging, and into the truly revolutionary changes in treatment, especially for advanced melanoma. And then navigating the world of non-melanoma skin cancers, the common BCCs and SCCs, the aggressive MCC, understanding their causes, how they look, behave, and how we treat them, plus a glimpse at the rarer types.
It's so clear that mastering this field, as laid out in a text like this, means seeing the connections, how the basic biology drives what we see, which shapes diagnosis, staging, and treatment. It's complex, but the principles are there.
Absolutely. And the pace of change, especially in systemic therapies, just keeps accelerating. It's a dynamic field.
As you, the listener, reflect on this deep dive, maybe consider this. We saw how pinpointing specific gene mutations like BRAF transform melanoma treatment. We saw a virus linked to Merkel cell, and how tweaking the immune system became a powerful weapon. What does this tell us about where cancer care is heading? Perhaps getting ever more precise, targeting the unique vulnerabilities of each cancer, maybe even each patient's individual tumor?
Think about what stood out most to you. Did anything change how you view skin cancer risk, prevention, or the potential of modern therapies?
Exactly. Getting this depth of understanding is what the deep dive aims for. Thanks so much for joining us on this crucial exploration.
It was our pleasure.